So we're now in the benign tumors looking at pituitary adenomas. Just remember the diagnosis or differential diagnosis for a suprasellar tumor includes a craniopharyngioma, a germinoma, an optic glioma, a meningioma, a pituitary adenoma, a germ cell tumor, an abscess, or a met. Anatomy, anteriorly, it's bordered by the clinoid processes. Superiorly, you have the diaphragmatic sella. Inferiorly, you have the sphenoid sinus, and laterally, you have the cavernous sinuses near the pituitary gland. The anterior lobe is everything else. Posterior lobe is ADH and oxytocin, or antidiuretic hormone, oxytocin, vasopressin, oxytocin. Microadenoma is a tumor that's less than 1 centimeter, and a macroadenoma is greater than or equal to 1 centimeter. So 1 centimeter is considered a macro or above. Just remember, pituitary adenomas are associated with multiple endocrine neoplasia type 1. This has the 3 Ps: parathyroid, pituitary, and exocrine pancreas. MEN2 is medullary thyroid cancer and pheochromocytomas. Prolactinomas will present with galactorrhea, amenorrhea, decreased libido, and infertility. Growth hormone secretion will cause acromegaly. Workup for a pituitary adenoma, do an endocrine evaluation, ask about headaches, vision loss, cranial nerve deficits indicating cavernous sinus involvement, ask about sleep, appetite, behavioral changes indicating hypothalamic involvement, do an ophthalmology consult with visual field testing to assess for bitemporal hemianopsia. Imaging, you want to get a thin cut MRI. You can also get a CT to look for calcifications consistent with craniopharyngioma. In general, these are hypodense / hypointense lesions. Remember that the pituitary generally is bright on T1. Residual tumor can enhance with gadolinium. Labs, you want to get prolactin. Prolactin greater than 20 sometimes can be high for other reasons. Greater than 200 is most likely a pituitary adenoma. Growth hormone greater than 10, not suppressed by glucose, high IGF-1. Growth hormone varies widely throughout a day, so usually check IGF-1, which is insulin-like growth factor, which is produced by the liver. ACTH, high cortisol, not suppressed, with low-dose decadron, is either normal or increased. Increased ACTH is consistent with Cushing syndrome. TSH, FSH, and LH. General treatment schema, observation versus surgery. Surgery is usually first. Transsphenoidal approach is usually ideal. Prolactinomas are usually treated with medications first. If you have a gross total resection after surgery, there's really no need for radiation. If you have a subtotal resection, you can consider observation versus radiation with SRS. Radiation if you have a functioning or secretory tumor. Radiation if ultimately growth would impact function, like visual deficits. Radiation can also be done if ultimate growth would compromise treatment options, such as SRS now versus external beam later. Otherwise, you can also observe a subtotal resection. Salvage radiation has the same local control as immediate post-op radiation. Again, here I say primary radiation if the patient is medically unresectable or refuses surgery. Otherwise, transsphenoidal surgery for everyone, or meds if it's a prolactinoma. Functioning other than prolactinoma is transsphenoidal surgery with adjuvant radiation, 6 weeks thereafter for persistent hormone secretion or subtotal resection. You can observe for a subtotal resection if it's not near critical structure, adjuvant radiation for all TSH secreting to a total of 54 gray. Prolactinomas you treat with medical management with a dopamine agonist first, even if the patient has visual symptoms. Surgery for failure of medical treatment, radiation only if they're inoperable, and failed dopamine agonist or subtotal resection with a persistent prolactinoma. Medical management, you give these before surgery. Growth hormone, treat with octreotide, which is somatostatin. Prolactinoma, treat with dopamine agonists like bromocriptine or cabergoline. ACTH, treat with ketoconazole. TSH, treat with somatostatin. Discontinue medical management before starting radiation. The evidence for radiation here favors external beam radiation over SRS if the tumor is less than 3 millimeters from the chiasm, or if marked extension into the cavernous sinus. For SRS, the tumor must be kept greater than 3 millimeters away from the chiasm. You keep the chiasm max dose less than 8 gray and the brainstem less than 12 gray for SRS. You generally want smaller tumors that are less than 4 centimeters for SRS. SRS is probably preferred over EBRT in general. Technique, planning constraints, SIM, CT and MRI fusion, supine, aquaplast mask, volume per Nancy Lee. It's the GTV plus 3 to 5 millimeters to PTV with no CTV in between. Planning is IMRT, 5-field with vertex, superior anterior fields, 3 to 5 non-coplanar arcs, or VMAT. Dose for external beam radiation in a non-functioning tumor. So let's just say non-functioning pituitary adenomas. You're going to do external beam. You're going to treat 45 gray at 1.8 gray per fraction. If you're doing SRS, you treat 14 to 18 gray. Generally, say 14 gray for the boards to the 50% isodose line. If you're talking about a functioning pituitary tumor, then you treat that external beam 50.4 to 54 gray. If you're going to do SRS for a functioning pituitary tumor, then you do 16 to 25 gray, say 20 gray on boards to the 50% isodose line. In-service exam states 20 to 35 gray for functioning for SRS dose. The constraints for SRS, just constraints in general, lens should be kept less than 5 gray, retina less than 45, optic nerves less than 50, chiasm less than 54, 8 gray for SRS, cord less than 45 gray, brainstem less than 55 gray, which is 12 gray for SRS, cochlea mean less than 35, mean less than 4 gray for SRS. Toxicity and follow-up local control is greater than 90%. Hormone normalization after surgery, 50 to 80% have normalization. It depends on the size and what hormone you're talking about. Definitive radiation has 30 to 50% hormone normalization. Can take 12 to 18 months for that to happen. Toxicity, the most common is hypopituitarism in over about half of patients. Growth hormone is usually affected first, median 3 to 5 years. Vision loss in 1%. If it occurs, it's generally 1 year. Risk factors include dose volume, compression from the tumor, even after resection, MS, distant Mets, diabetes mellitus, hypertension. Secondary malignancy in 1 to 2%. You may need levothyroxine or growth hormone analog for replacement. Treatment for diabetes insipidus is desmopressin. Follow-up, MRI every 6 months times 1 year, then annually. Endocrine lab panel. Annual visual field testing.